Good afternoon. Welcome to Days of Our Lives. That's a joke.
Pity laugh. I'm just kidding.
Anyways, I'm here with Jessica and Mike, and the only reason we really have antibiotic stewardship programs is to monitor vancomycin, so I thought I would tackle a little bit today. It's a hard topic, but I don't think we can stop vanco, but it's something you have to be vigilant about. So I wanted to give a little overview of vancomycin, which I just saw at UCLA is their second most, the medical center there I saw was the second most prescribed antibiotic. And I think
that's Vanco for us is either 1 or 2, depending on how you cut the numbers for us too, in terms of usage.
All right, so we're going to talk about what's called the elephant in the room, vancomycin. All right, so vancomycin update is Vanco's dose of the answer for everything. And this was actually an article I took that from some emergency room guy, and he said it was good for everything. So we're done. Anyways, vancomycin update. A few boring slides. I'm just going to review a little bit of background about vancomycin, and just if you're not, just update you on, just review some of the microbiology, what means gram-positive, what means gram-negative. So vancomycin is what we call a glycopeptide, and it works on the cell wall of bacteria. And most of the antibiotics that work against the cell wall, as you know, are the beta-lactam. So vancomycin is a non-beta-lactam antibiotic, and it actually attacks the cell wall, just like the penicillins and the cephalosporins. And what it does, by attacking the cell wall, some of the enzymes that make the cell wall strong, called peptidices, penicillin binding proteins, are not able to function properly, and the cell wall falls apart. So vancomycin blocks bacterial cell wall production. So obviously it's not going to work against gram-negatives, which you see on the left. The gram-negative has a membrane in front of it, so vancomycin is not able to get through that membrane to attack the cell wall, which is between sort of like an Oreo. It can't get inside, so it has no activity against gram-negatives. And on the right, you see gram-positive, with that big cell wall. We have big peptidoglycan chains, and then they're little like twist ties that hold it in place. And those are the penicillin binding proteins, which make the cell wall strong. Okay, so the cell wall, when we talk about gram-positive, well, basically if you look under the microscope, gram-positive, gram stain adds violet to it, and the cell wall picks it up. So you look under the microscope, if you have a gram-positive, it means basically it looks violet under the cell wall, and it's a gram-positive organism because the cell wall is on the outside. Gram-negatives, where the cell wall or the peptidoglycan chains in the middle, it doesn't pick up that the violet coloring, and so it looks pink. So gram-positive, basically, it has the cell wall on the outside, so it's vulnerable to vancomycin, and vancomycin has activity against it. So when you get called, the microbiology lab will call you saying we have gram-positive cocci on a blood culture. Both on the left, we see staphylococcus in those clusters, looks like grape-like clusters. Makes it, in contrast, strep, which is also gram-positive cocci, looks more in chains. So you want to know they're both gram-positive organisms because they have cell walls on the outside. But you can call the micro lab and say, hey, are they in clusters or are they in chains? And usually they'll be able to tell you, because if it's in chains, then you're not dealing with staph or MRSA. It's just a strep. Versus if it's in clusters, it could be MRSA, it could be Staph aureus, it could be coag-negative staph. Okay, so gram-positive in clusters, staph, gram-positive in chains, everything from pneumococcus to strep to enterococcus. But that's something that can help you real quickly if you do like a sputum, or you have a lumbar puncture, and they can tell you what if it's gram-positive organisms, is it chains or clusters. But again, what we're talking about with vanco, we're talking mostly against staph and not the strep infections. So this is the spectrum of vancomycin. Again, the answer is gram-positive bacteria. If anybody else what does vanco cover, it's gram-positive bacteria. And it doesn't matter whether it's aerobic or anaerobic. So it has activity against it. Clostridium, which we use vancomycin orally for C. diff, is a gram-positive rod. And again, it has activity. So anything that's gram-positive, it works against, but does not work against any gram-negative organisms. So usually when you're treating broadly, you may give the Vanco for gram-positive organisms, but you need to give coverage for gram-negatives, which are, enteric organisms, E. coli, and anaerobes, like beef rats and stuff. Okay, so we see methicillin susceptible, methicillin resistant. So methicillin resistant, the difference between methicillin susceptible and methicillin resistant is just that methicillin works, like all the penicillins, the beta-lactams, also works on blocking the cell wall. We saw it over here on the right, the gram-positive cell wall. But what happens is that the enzymes that it blocks, the penicillin binding proteins, aren't able to bind to these altered penicillin binding proteins. So methicillin, which is sort of stands for cefazolin, penicillin, it no longer works. So we call those methicillin resistant. Vancomycin is not affected by the mutations which cause methicillin resistance. So it doesn't matter whether it's methicillin susceptible or methicillin resistant. Vancomycin is not affected by that. So it works against susceptible staph and resistant staph. It works against strep pneumonia, strep viridans, enterococcus, listeria, pectostreptococcus. So any gram-positive organism, whether aerobic or anaerobic, it has activity against, again, because it's only attacking the cell wall. And so the clinical uses, there's a long stuff, but you can imagine anything that involves staph. So you can have bacteremia, you can have empyema, which is an infection in the lung lining, endocarditis, peritoneal infections, pneumonia, skin, soft tissue infections. And those are indications for, that vancomycin can be used. And again, even if somebody has a methicillin susceptible, let's say they're allergic to penicillin severe, vancomycin will also work in that because it's not affected whether it's methicillin susceptible Staph aureus. All right. And we use it also for surgical prophylaxis. You're putting a prosthetic hip in. You may have some resistant MRSA in your hospital, resistant Staph epi, and vancomycin. So anything that has a lot of indications. So let's just review some of the side effects. This is some people get confused about. There's two skin conditions, and one is called red man syndrome, which doesn't sound very politically correct, but that's what they call it. And this is what?
The devil.
The devil. Looks like the devil. So this is totally different. This is not a true allergic reaction. And what happens, vancomycin, if it goes in too quickly, causes histamine release from mast cells. Mast cells release histamine, and what you give you those, the same thing that makes you sneeze and wheeze and stuff like that. And so you get a histamine release, you get a severe itchy rash, very unpleasant, but it resolves pretty quickly within an hour or two, and it's usually just treated with antihistamines. Okay, so that's the red man syndrome. So if somebody says, I got vanco and I got a bad rash and I had to stop the infusion and went away, that's red man syndrome. This is different than a standard. You can also get a standard rash. So you'll have people get vancomycin, they've been on it for a week or two, and all of a sudden they get this horrible rash. And that rash is, diffuse, but it's not a rash that clears up in 2 hours and it stays there for days or for even many days because the vancomycin hangs around. So that is an allergic reaction. So actually, this is the red man syndrome. Sorry, this is a red man rash, where you can see how on the skin, you can see it looks elevated, very itchy and stuff like that. So this is the red man syndrome, the histamine-mediated one. But if you compare it to, this is, you can't see that much difference, but this is a typical drug rash, just like you get a typical drug rash to penicillin or any other medicine. It's not usually urticarial. It doesn't clear up quickly, and it doesn't resolve with antihistamines. Okay, so red man syndrome, acute, flush it. You're giving the infusion too quick, slow it down. This is a real drug rash that lasts for days, and you don't want to re-challenge these patients. So when patients tell you that they're allergic to vancomycin, you really want to get history. You want to add anything about that? Or?
No, it's true.
Yeah, if somebody reacts, we just slow down the infusion and consider, and if that doesn't work, we'll do Benadryl. And generally, 9 times out of 10, if not more than that, you can work through that infusion-related reaction.
But you also see regular rashes to Vanco too.
It's rare.
Yeah.
It's rare.
But you can't get it.
Yeah, absolutely.
Yes. All right, so the second issue that we're going to talk more about is nephrotoxicity. And this is sort of a controversial term, consideration. These were studies from about 10 years ago where that they thought that vancomycin nephrotoxicity, which they defined as a greater than 25% reduction in GFR, was trough related. And so there's this big emphasis on trough monitoring to try to reduce the risk of it. This is not exactly always agreed at this point. So this was a tradition. They said, your trough's too high, you're going to knock off their kidneys. So this is another study which has gotten a lot of attention recently, the recent studies, where vancomycin in itself may not be as toxic as when it's combined with certain medicines, particularly pip-tazobactam. As we know, pip-tazobactam, otherwise known as Zosyn, is the go-to regimen for everybody who comes into the emergency room who's even mildly sick. And so this was the biggest study. So this study wants to say, is it really true that this combination is almost synergistic in terms of causing renal toxicity? And this article came out last year. It was called Nephrotoxicity During Vancomycin Therapy when it's used in combination with Zosyn or cefepime. And this is from University of Kentucky Healthcare. And this was a retrospective study, and they looked at over 4,000 patients, which they had treated for 4 years. And they basically got rid of people they didn't include patients on dialysis, pregnancy, chronic kidney disease, cystic fibrosis. So these were patients who basically had normal renal function and where they could study the factors. And what they did was they tried to match patients on multiple factors, as many as possible, for example, age. And they gave them the vancomycin. Some of the patients got cefepime, and some patients got Zosyn. Both cefepime and Zosyn have similar broad spectrum activity. They cover gram-positives. They don't cover MRSA. They cover enterics. They cover some ESBLs, and they cover Pseudomonas. So oftentimes they're used interchangeably for broad spectrum coverage. So they wanted to see, could they figure out why, who developed renal insufficiency. So they matched these patients. Since they had thousands of patients, they were able to match them as close as possible. Age, sex, whether or not they got contrast exposure from radiology, severity of illness, trough concentrations, and a bunch of other confounding factors. And after adjusting for all these factors, they found that acute kidney injury developed in over 21% of patients who were on Zosyn and Vanco. And if they got Vanco and cefepime, there was only 12%. And they said the probability this was significant was, like 1 in a million. That it was not significant, it was 1 in a million. And so they were just saying that, it's not so much the Vanco, that there are other factors which can contribute to renal insufficiency. And as you know, Vancomycin is given out like water in most hospitals. And they say it reinforces the need for judicious use of combination empirical antimicrobial therapy. So that's where, the antibiotic stewardship program and that we all emphasize to try to control that.
Just a point on a lot of the studies that have shown, this is not the only study that's shown an increased risk of nephrotoxicity with vancomycin, but the commonality is relatively long durations of the combination therapy. And by relatively long, I'm talking about more than 4 days. That's when you start, so not that long, but more than 4 days is really when you start seeing that the toxicity happen with the combination therapy. So if you use it up front, you need to start de-escalate. I mean, if you need it at all is the question, but if you do start it up front, de-escalate as early as possible to prevent this nephrotoxicity from happening.
Is there any theories about why?
I don't think they know the mechanism. I don't know if Kim or Carol have anything to add, but as far as I know, they don't know the mechanism.
Yeah, I do it.
There was, I think, a more recent one that came out, and that showed that Zosyn by itself was more nephrotoxic than even Vanco. So I don't know if it's just with the beta-lactams that we think about ATN, like with the older drugs, but I don't think they really had a true theory. But it was interesting that even Zosyn was more likely to cause nephrotoxicity as a monotherapy than Vanco.
Really?
Is it like an interstitial nephritis type thing, or?
I really don't think they know the mechanism is what but I mean, yeah, that's a good thought.
Because the beta-lactams we usually think as totally non-kidney toxic.
Yeah.
So that's a pretty significant finding there. Again, vancomycin is used, just about everybody gets that combination therapy.
I know it's not necessarily related to Vanco, but I oftentimes get the question of, well, are you using something else besides Zosyn? Then empirically, so are you using cefepime? Or are you using a carbapenem? And no, Zosyn's really still our go-to for broad spectrum empiric coverage. But again, with a strong de-escalating early. And the reason why is while we know that it's a more nephrotoxic combination, we actually don't know necessarily if there are other toxicities that we need to be concerned about, especially the neurotoxicity associated with cefepime. There's a lot of neurotoxicity that goes under-recognized with cefepime. And so what is that? What's the overall outcome to the patient? We really don't have those head-to-head trials yet saying that combination is better for the patient than Zosyn and Vanco.
I wasn't familiar with that. I don't use much cefepime. So what kind of side effects?
Any kind of it could be seizures, just encephalopathy in general. Some of it's permanent. So just something to keep in mind, especially if you have a patient on the vent who's not weaning or increased confusion or delirium. Cefepime should be on your differential.
Sounds like Cipro.
It does, yeah.
Thinking the same thing.
Yeah.
I didn't know that
Yeah.
either.
And it happens even when you dose adjust for renal function. But I think it's under-recognized a lot. But
Have you seen it?
Yeah.
That's interesting. Anybody else been aware of that or seen that before? Probably just so many patients that eventually you'll see that stuff. All right. So one of the consequences of vancomycin toxicities, as you can imagine, when they look at patients with MRSA bacteremia who develop acute kidney injury, patients with acute kidney injury spent an average of 7 days longer in the hospital versus somebody who didn't develop acute kidney injury. And if you were in the ICU and you developed renal toxicity, you spent an extra 5 days versus somebody who didn't develop it with a MRSA infection. What's interesting is I always think it seems like more patients are requiring hemodialysis, but in these studies, there's only a slightly increased risk of these patients eventually needing hemodialysis. Have you seen people getting on hemodialysis with Vanco?
it's always been a multifactorial cause, so it's hard to tell how much, or generally, so it's hard to tell how much.
We're watching it pretty close, so we were
watching go to 4 to 5 to 6. And,
we're pretty quick to, if we see even a slight bump, we're pretty quick to use alternatives, even if it's more costly.
Yes, and obviously increase the hospital costs in with these patients. So vancomycin's used a lot, and maybe the question is, instead of dealing with the toxicity, let's prevent using it so much. And what can we do to reduce the use of vancomycin, okay? And this was an interesting article that looked at community-acquired pneumonia. So this was 2,500 patients called Staph aureus community-acquired pneumonia, prevalence, clinical characteristics, and outcomes. So this was a study from, what was it? Oh, yeah, it was in, I believe, Vanderbilt University. They had a whole bunch of hospitals in Tennessee and Chicago. There's 5 major hospitals. And they wanted to look, what is the prevalence of MRSA in really community-acquired pneumonia patients? So they got rid of anybody who had, quote, healthcare associates. So they got recent hospitalizations, cancer patients who may have gotten cancer drugs, skilled facilities, dialysis. So these were clean cap patients. And they followed, they looked at 5 hospitals over 2.5 years, and they had 2,259 patients. And 30% of these patients were admitted from the hospital, from the ER, got anti-MRSA antibiotics. So that's basically what we see here around here. 30% got either vancomycin or linezolid for community-acquired pneumonia. And then they go to the cultures. 1.6% of these patients had Staph aureus, not MRSA. So even drugs like Rocephin may have some activity against it. And MRSA pneumonia, in a community-acquired pneumonia, only 0.9% of patients had MRSA. So less than, so out of these 2,259 patients, they only had about 3 or 4 or 4 actually had MRSA pneumonia. So they looked at who the 0.9% was. If they're admitted to the ICU, 2.7% had MRSA. Okay, so it was 3 times more prevalent in the ICU patients. If the patient was admitted to the floor only, 0.1% had MRSA pneumonia. So 1 out of every 1,000 patients admitted to the floor had MRSA. At the same time, 30% of these patients were getting vancomycin up front. So the bottom line, when you look at all the MRSA infections, 0.9 and 30%, only 1 out of every 30 patients who were given empiric MRSA coverage for CAP actually had MRSA. So one
How
way
many had
is,
nephrotoxicity?
what? Oh yeah,
I'm just kidding.
I think it talks about
Oh, does it?
if a community-acquired pneumonia is not sick enough for the ICU, it's very unlikely to have MRSA pneumonia. And if you look at the guidelines are, Rocephin and Azithro or Unison and Azithro or doxycycline. So the standard guidelines for a community-acquired pneumonia patient not in the ICU doesn't even recommend these drugs. All right, so I think we're over-treating a lot of CAP, okay? And we've talked here previously with Mike and stuff. MRSA pneumonia is not a joke, okay? You are sick as a dog. So, you got 100.5 degrees and you're on 4 liters of oxygen. You haven't got MRSA. You have MRSA pneumonia, you are sick, 104, 105, you're at Rikers, you have an ugly x-ray. It's usually, so don't follow the guidelines. I mean, follow the guidelines, but look at the patient. The patient's sick and more than your average bear, then consider it. But don't just routinely, this is pneumonia, the guy's septic, we need to give vancomycin.
Jessica and I did a study when I was over at Renown, and we were looking at hospital associated. So
Yeah, HCAP.
and we went by the rule that we talk about is if it's, bad bugs cause bad disease. So if they're just admitted to the floor and they're not that sick, we would put them on our community acquired regimen. And we looked at, after I can't remember the time, but we looked at so many patients. And what we found was there was no difference in mortality, but there was a difference in length of stay. So once you get stuck on vancomycin, you're going to probably be in the hospital longer than if you were put on ceftriaxone and azithromycin.
For non-MRSA infections.
Well, yeah, these were, none of them, they didn't come out MRSA. That was the thing. It was the whole thing about if they're sick, they're going to be in ICU. If they're not sick, treat them like a community-acquired pneumonia.
Yeah, so just going broad, it's not doing a patient a favor. It actually has more toxicities with it. So this is just a typical case that we round on about 10 times a day at the various facilities. 67-year-old overweight diabetic male admitted with cellulitis, severe sepsis. So he's a sick man, he's got cellulitis. History of peripheral vascular disease, neuropathy, and ulcers on his feet. And he's seen wound care at the hospital clinic. So healthcare associated, sick guy. He develops confusion, fever, rapidly progressive rash moving up his legs. He has a fever, tachycardia, and blood pressure. So normally the ER doctor starts vancomycin, okay, for severe sepsis diagnosis. But if you just look at the leg, you can see cellulitis rapidly going up the guy's leg. You see probably around his ankle, probably that ulcer there was probably the site of an infection, but there's no pus, okay? So, diabetic, rapidly progressive cellulitis, there's no bullseye, no blisters. He just has cellulitis, okay? Doesn't matter where he's been. To me, this would probably be a group A or group B strep, but he's going to get vancomycin, and we see this over and over again. So we walk around, we see these patients, we can't express any pus, and we would, simplify quickly to either give her the vancomycin, put them on Unison or ampicillin to cover group A or B strep. So, you can have all the guidelines in the world, but if you don't look at the leg and just rapidly go vancomycin for everybody, you're not doing the patient any favor. And the vanco and this guy's sick, you could easily, and he's on Zosu, you easily give him acute renal failure. And so,
You gave a lecture on looking at wounds.
Yeah.
Remember
pseudocellulitis, or
I don't know. It was
cellulitis.
one of the ones in Echo, but we
Yeah.
looked at a bunch of different cellulitis, leg wounds, and so on. And we were trying to get them to look to see, do you think this is staph, this is strep?
Right. Yes.
Or is there gram-negative rods? There's obviously no gram-negative rods.
Right. Yeah, it's a cellulitis. The guy's sick. He's poor health. His diabetes. He has ulcer, but it's still not going to be. It's not going to be something that you worry about MRSA or you worry about deep infections.
And then one of the things I get is but it's draining a lot. And talking about that serosanguinous drainage, that's not purulence. So staph would produce pus. Yeah. That this is clear yellow.
Yeah.
Drainage.
So lymphedema. All these people with lymphedema, and they get these ulcers from their diabetes and their weight, and they all the fluid just pours out. But that is not pus. So that's just lymphedema fluid. All right, so this is, okay, so one way is looking at pneumonia, community-acquired pneumonia, maybe not giving Vanco to somebody who's not on the floor. Secondly, looking at the cellulitis patients. If you don't see purulence, you don't feel crepitance, it's a typical rapidly moving strep, don't do the Vanco Use. So now this was a study I presented a few months ago, I just brought it up. This is in the ICU, where it was done at Mercy Hospital. And what they look at is ICU patients who were admitted and placed on empiric MRSA antibiotics as part of their initial regimen in the ICU. And they had sputum and blood cultures done. And some of the patients, they all had negative sputum cultures and negative blood cultures. So they went through their hospitalization, what evidence of MRSA coverage. Some of the patients, the physicians stopped within 24 to 48 hours. And other patients, they just continued the same coverage, at least an average of 5 days. So these are patients who did not have MRSA, not found to have MRSA, but some were continued on this, quote, broad-spectrum antibiotics. Because typically you walk around the ICU and they say, oh, I really hesitant to change things because they're doing better. And what they found out was that when they looked at outcomes, there was no difference. Okay, so the bottom line was, if you don't have any evidence for MRSA in the ICU after 48 hours, you're not helping the patient out by continuing antibiotics. There's no improvement. Just being on broad-spectrum antibiotics is not somehow better for them than being on more focused like a Rocephin. So their recommendation was that there was no advantage to continue use of anti-MRSA antibiotics if cultures are negative. So consider stopping within 24 to 48 hours if you do not have any evidence of MRSA. And so that's something to think about it. And I presented this, I think, last month, and this is really excellent what we're talking about. This was a thing, an open form infectious disease came out last month called Microbiology Comment Nudge Improves Pneumonia Prescribing. And what they did, this was from Henry Ford Hospital in Detroit, and they were looking at patients who got community-acquired pneumonia or anti-pseudomonal pneumonia, and they saw if after 48 hours their sputum came back as normal flora, did they stop the broad-spectrum antibiotics? And so they looked at that, and then they, for another 6 months, they had the microbiology report, not just normal flora in the sputum culture, but normal flora only, no Staph aureus, no MRSA, no Pseudomonas isolated. And they educated the physicians, say, hey, look, normal flora, we're telling you that there's no Staph, there's no MRSA, no Pseudomonas, so things that you would have indications for vancomycin. And what they found was that they looked at before and after this position was taken. They found a median 2-day decrease in broad-spectrum coverage, stopping vancomycin as compared to baseline period. And the patient and the physicians were 5 times more likely to de-escalate when they got this thing than previously, when just a normal flora. There was no mortality difference like in the other study, but they found a significant decrease in acute kidney injury. Okay, so we can't sometimes stop people from doing vancomycin, but I think we can try to intervene sooner and do this step. And I think so far we're doing it at some of the hospitals I work at. We're going to get the statement on there. All right, so a few pointers to reduce vancomycin use. A patient with CAP, community-acquired pneumonia, who isn't in the ICU, isn't spiking high fevers, and doesn't have cavities on chest X-ray, very unlikely to have MRSA pneumonia. Go with the Infectious Disease Society of America guideline, Rocephin azithro or Rocephin doxy or Unison doxy or azithro. Don't use empiric vancomycin for these patients. Just stop it, okay? If you got MRSA pneumonia, you're sick as a dog. If you're in the ICU with pneumonia and blood and sputum cultures do not show MRSA after 48 hours, stop the vancomycin. They don't have MRSA pneumonia, okay? Don't use vancomycin for non-purulent cellulitis. If it's just a strep cellulitis, treat it for strep. Try cefazolin, Unison, or simply ampicillin for those patients. Get away from the vancomycin. And the other thing is, I've seen cases, again, the pseudocellulitis, where patients are treated over and over again with antibiotics. And I gave a talk recently on pseudocellulitis, where 40% of cellulitis cases are not infectious. They could have lymphedema, they could have stasis dermatitis. So if you see somebody who's failing antibiotics, instead of upgrading from, Unison to vancomycin, maybe they don't even have the diagnosis of cellulitis. We just had a patient the other day, 2 weeks of outpatient antibiotics, and the patient had an ischemic toe. Okay, the patient needed the toe amputated, but had redness around it, so she was on vancomycin or some crazy regimen. All right, and if you can avoid vanco plus Zosyn, very high risk for nephrotoxicity. So, infection control, antibiotic stewardship, this is a very difficult, you just have to stay on top of it and continually reviewing why patients are antibiotics, but I think that's what I wanted to say. Any thoughts, you guys, or? Yeah.
I think the other thing, there's really not a role for vancomycin in at least community onset intra-abdominal infections or in urinary tract infections. So you really shouldn't be even really initiating vancomycin in those populations unless you have some sort of culture confirming MRSA, which would be unusual, very unusual. But those are some indications that are easy targets as well.
If you've had a procedure or you have a Foley, then it might be an issue, but not community acquired.
Yeah, and usually not empirically. You don't, unless they have a history of enterococcus. Even then, only ampicillin-resistant enterococcus.
That's no big deal.
Yeah, exactly. They're not the patient dying in the ICU.
Yes.
Any questions or anything we want to discuss before we wrap up for the day?
I have a question. Can you guys hear me?
Yeah, go ahead.
Oh, hi. This is Monica Marins from Barton Hospital in South Lake Tahoe. Do you guys use just MRSA nasal swabs very often to kind of see, if somebody's really sick, but their MRSA nasal swab is negative? I remember hearing, I think at IDSA week, that the chance of having then an MRSA infection is quite low. It was like less than 0.4% if the nary swab was negative. Do you guys look at that much when you're trying to decide whether to use Vanco?
We don't use it to decide whether or not to use vancomycin. We use it as ammunition for de-escalation if negative.
Okay.
And we have because it's really hard as a pharmacist to, at least for us to, to convince a provider, oftentimes you don't need the Vanco up front. And so we have a pharmacy protocol that if they order vancomycin or linezolid for a pneumonia admitted to the floor, so a non-ICU patient, pneumonia admitted to the floor, we can order that MRSA nary swab per pharmacy protocol. When that comes back as negative, we then have a conversation with the provider. And there was actually a recent meta-analysis published, I think in the last couple of months, supporting this, that the likelihood if you have MRSA pneumonia when you're not even colonized with MRSA is incredibly, incredibly low. And then the other point of that though is if you get an MRSA nary swab and it's positive for MRSA, that does not mean that's what's causing the pneumonia. It just means they're colonized.
Okay, because I use that a lot too as ammunition.
Exactly.
The swab's negative. Let's go ahead and de-escalate here.
And it probably works for an ICU patient as well, but it's the risk of it being MRSA is just because MRSA causes severe pneumonia, ICU-like pneumonias. It's not quite as good as in the ICU as it is on the floor. So you want to look at take all things into consideration. Look at your patient, as Dr. Krasner would say.
But the other thing, if you're in ICU, if you have a MRSA or Pseudomonas pneumonia, that grows out pretty well.
Yeah.
I mean, if you had a culture and it's negative, you don't have it.
Yeah. So if I had an MRSA nary swab that was positive in a sputum or a good respiratory specimen that did not grow MRSA, I would feel comfortable probably seeing the Vanco.
And you'd be sick as dog with MRSA, so you're not gonna.
Or even talk about ICU. I mean, even in ICU, you can use this.
Yes.
Thank you.
Thanks for the question. Anything
I
else?
have a question.
Yeah.
I have a question. If I understand this correctly, this is Suzanne. The vancomycin you would initiate at your, when you don't know your culture results, and then once you get your culture results, you can then specify to a better ampicillin or whatever. Is that correct?
Yes. Yes.
Okay, and then, so when you
Yes, but if it's depends on the if it's an pneumonia, like a community acquired pneumonia, it shouldn't even be started.
right, okay, unless it was an ICU severe pneumonia.
ICU,
Okay.
exactly.
Yes.
Okay, so then I was just curious, has there been any correlation then on the length of vancomycin given to C. diff patients? That do they then develop kidney problems because of that, them being on it for so long?
Vancomycin, it's the nice thing about vancomycin orally is that it's not absorbed. And so unless you have severe colitis, very little gets into the system. So that's why you don't give IV vancomycin for C. diff. It has to be given orally. And so that's not an issue at all. So just,
Oh, I see. Just
yeah,
to get it in the GI tract.
correct. Yes.
I see. Okay, thank you. Thank you. I was confused there. Thanks.
Well, thank you very much.
Thanks, everyone. We'll be back next month, Thursday, September 20th. So we'll hope to see you there. Thank you.
Thanks for the questions.
Thank you.